Hello, everyone. It's been an interesting couple of weeks, and it's been an exciting couple of weeks. We have a new set of protocols that brings us into 2025, and we are extremely excited about that. I'm just going to bring you an introduction to those protocols and go over the changes. I'm not going to take a deep dive into each one of those changes because in the next couple of weeks, I'm going to be bringing you a series of videos that introduces those changes and bring you some literature that introduces those medications so you can become better acquainted with those things individually. So to begin, we're going to start out with the BLS changes, and then we're going to go into the ALS changes. So starting out is one that I'm extremely excited about. It's the fact that EMTs can now give oral Zofran. They can give 1 to 2 oral disintegrating tablets, which is 4 to 8 milligrams. EMTs have also been able to give Tylenol for quite a bit of time now. We've had that in the fever and the pain management protocol, so I just wanted to highlight that. They can give the tablets or the suppositories or the liquid. Another PO medication which is coming that EMTs can give is famotidine or Pepcid, and that's coming to the allergic reaction protocol, as well as PO Benadryl. So those are going to be medications available for everyone. So as long as the person having the allergic reaction can still swallow, those medications are going to be available for the BLS level and the ALS level. Also, the epi dosage for asthma and reactive airway disease and anaphylaxis at the BLS and ALS level, the dosage is changing from 0.3. It is now going to be 0.5 milligrams. So take a minute to acquaint yourself with the fact that it is now in the asthma and reactive airway disease protocol now, as well as the anaphylaxis protocol. Another change which is coming is the fact that we have included nitroglycerin in the pulmonary edema CHF protocol. And the dosage is 3 0.4 milligram tablets per dose. It is a total of 1.2 milligrams. And that's at the BLS and the ALS level, as long as the systolic blood pressure is greater than 130. So now we're moving on to the advanced EMT protocols. Advanced EMTs can now give epinephrine 1 to 10,000 for cardiac arrest. That is a change effective with these new protocols. We're really hoping that we can push advanced to be able to practice to their full scope with these new protocols and in the coming protocols that we're producing. Also, just a reminder that EMT Advance can give IV Tylenol for pain management. In talking with Dr. Qualls, he is wanting to see an increase in using IV Tylenol as the frontline pain management agent as opposed to narcotics. So now we're moving into the paramedic protocols. So beginning with Cardizem. For irregular tachycardias, so for example, what you would identify as rapid AFib, we are adding Cardizem, which is a calcium channel blocker. We are also adding lidocaine back into the protocols for ventricular tachycardia, ventricular fibrillation, and stable wide complex tachycardias. When we talk about rapid sequence intubation, we're adding the option for rocuronium as a paralytic. Dr. Qualls has identified that as the preferred paralytic in most pre-hospital as well as in-hospital agencies over vecuronium. We're adding ketamine as an option in several instances. We're adding it for RSI, for pain management, procedural sedation, as well as behavioral and chemical restraint. We're adding tranexamic acid for hemorrhage control. That is a big step forward for internal hemorrhage control. So acquaint yourself with that protocol. We're adding steroids, either Decadron or Solumedrol. The research is solid, which shows that pre-hospital steroid use for anaphylaxis and reactive airway disease, as well as croup, is very beneficial to all patients. Even though we may not see the benefit immediately, the research is absolutely conclusive that this is in the best interest of our patient. When we talk about pressors, we're looking at Levophed and epinephrine drips as opposed to dopamine. The research is sound that both of those are less harmful to our patient populations and cause less side effects than dopamine. We're also adding an option for push-dose pressors, which is a stopgap which allows immediate treatment while setting up a drip to try to resuscitate your patient. I'll go into those further in the coming weeks. We're adding Phenergan and Compazine as options for antiemetics. Working with Dr. Qualls, we've identified the fact that Zofran works well for nausea, but once the patient is vomiting, it does not do a great job. So Phenergan is a 12.5 milligram IV bolus, and Compazine is a 10 milligram IV bolus. We're looking at adding Ativan back into our repertoire for chemical restraint as well as for seizures. We're looking at adding calcium chloride back in for calcium channel blocker overdoses as well as hyperkalemia. One big one is adding antibiotics, the antibiotic Zosyn. And this is going to be for sepsis, for penetrating trauma, and it's also going to be for any procedure that we perform. So if we perform a thoracostomy, if we perform a field amputation, or anything of that nature, we're going to be administering antibiotics because we are introducing an infectious route into the body. The last thing having to deal with medications that I'm going to talk about is we've added a procedural sedation protocol. Because we're adding procedures to our repertoire, we need to have a way to make sure our patients are comfortable when we're doing these procedures. And so there is a protocol now to make sure that our patients are comfortable when we're doing these invasive procedures. In terms of procedures, we know that we've added the thoracostomy to our repertoire. The thoracostomy is preferred over the needle decompression. The research is sound that thoracostomies are the way to go. They are endorsed by ITLS and by several other agencies. We have added the field amputation protocol, and while we don't anticipate that anyone will ever use it, it is something that needs to be reviewed, and we will talk more about it and go over it. There is also the perimortem C-section protocol, which is the last thing we will talk about. That is something that we all hope we'll never have to use, yet it is something that we need to have in our back pocket at the end of the day. That is a summary of the changes, and I hope you are all as excited as I am about everything we have going on. Have a great week, and I'll be putting out some more information about all of these changes. Thank you.